So the case presented today is a 70-year-old man with symptomatic drug-refractory persistent atrial fibrillation. This patient had no structural heart disease, a Seitz VAS score equal to 1. The left ventricular ejection fraction is normal and the left atrium is a little bit dilated. An electrical cardioversion was performed 1 month ago, but the patient experienced atrial fibrillation recurrence. The patient is right now in atrial fibrillation, and we will perform an electrogram-based substrate ablation of his atrial fibrillation. The procedure is performed under general anesthesia. A triple femoral puncture is performed. A thermal probe is used to monitor esophageal temperature during ablation. A decapolar catheter is positioned within the coronary sinus. I'm on the septum. The transseptal puncture is guided by fluoroscopy and transesophageal echocardiogram. Okay. I'm in the left atrium. 3 different types of electrograms considered to be involved in the electrophysiological process of AFib perpetuation are targeted by ablation: CFAE, rapid fires, and temporal gradient of activation. A special attention is paid to continuous and low voltage CFAE, as you can see here. Rapid fires are defined as discrete electrograms of very short cycle length, usually around 90 milliseconds. A temporal gradient is defined as an activation gradient between the electrogram recorded by the distal bipole in relation to the proximal bipole of a quadripolar catheter. It hints to the possibility of a localized re-entry. A multipolar catheter is used to reconstruct the left atrium geometry and to detect and tag targeted electrograms. So the AFib cycle length measured in the left appendage is equal to 160 milliseconds. You can see here the temporal gradient of activation and CFAE potentials in the proximal part of the coronary sinus. You can see here great fractionation on the ridge. You can see also here fractionation and rapid fires in the posterior wall close to the left inferior PV. 6, 7, 7, 8. The ablation catheter is now introduced. You can see here a great fractionation in the proximal part of the CS. Perfect. We start now substrate ablation. The strategy of substrate ablation consists in the elimination of targeted electrograms without PV isolation. The endpoint of the ablation is AF termination and non-inducibility. 1 minute point-by-point applications are performed using the contact force technology. We use ablation power control dynamic settings. I will start the ablation in the proximal part of the coronary sinus. 25 watts. You can see here a great fractionation in this area. Okay, so we start ablation. It's 4:16. You can see here in the proximal part of the CS mid-diastolic electrograms in fibrillatory waves. Okay, Fanny, 30 watts. We then go in the left atrium. Okay, lots of CFAE on the ridge. 40 watts. Okay, 40. There are some good electrograms, very fractionated on the septum. 45 watts. All right, 40 watts. 35. 40. 30 watts. Okay, 25. Okay. So the esophageal temperature is increasing. So I stop my application on the posterior wall. Okay. So AFib is now well organized into atrial tachycardia. You can see here a mid-diastolic electrogram between atrial tachycardia P waves corresponding in the electrical isthmus of this localized reentry. 40 watts here. Sinusal. $45. Okay, so we terminate atrial tachycardia on the septal part of the mitral annulus, on the pink dot you can see here. So we'll try to reinduce AFib with fast atrial burst. We perform an inducibility testing in order to eliminate residual substrate. Okay, sinus. We'll try to reinduce again. Stop. Sinus. Okay, we try to reinduce again. Faster, faster. Okay, stop. After AFib reinduction, a complementary ablation is needed in the proximal part of the coronary sinus. Sinus. Okay, you can tag these points. The coronary sinus is a real important part of the atrial fibrillation substrate, especially his proximal part. So we'll burn during 2 minutes here. Okay, so we'll try to reinduce AFib again. Stop. An organized atrial tachycardia is reinduced by atrial pacing. You can see here a mid-diastolic electrogram between P waves. 25. Okay, we terminate AFib here again. I use the 3D geometry to pass the septum to go in the left atrium. Okay, so we'll try to reinduce AFib again. So you can pace one more time to try to reinduce AFib. Sinus. Okay. So we terminate AFib by electrogram-based substrate ablation in the left atrium 1 time and in the proximal part of the coronary sinus 2 times. AFib is not inducible anymore, so we will stop now the procedure.